So it's my pleasure to introduce Brendan Spiegel. He is visiting us from Cedars, right down, sort of down the street, and has some really interesting work going on. And I will just let him proceed. Brendan.
Okay. Good morning, everyone. Good to be back. I was here last year. This was a great conference, and you guys are an excellent group of learners. So it's terrific to be with you guys, and I'm sure you always have a lot of questions, and I look forward to some conversation. So I've been asked to talk about how we are sort of strengthening health systems from the perspective of a large health system, Cedars-Sinai Health System. We have the largest hospital in the western United States. And I want to give some examples of how we've been using digital health technology broadly and mobile health in particular for our patients in the clinical trenches. Now, my background is I'm a physician. I also am a professor of public health here at UCLA and professor of medicine. So I take sort of the perspective of a clinician scientist, but also as a public health scientist, health delivery scientist, and think about how to pragmatically employ these technologies on the front lines of care. And I'll give you some examples of what's working and also what's not working when we use these technologies. Now, on this picture is me with one of our now almost 3,000 patients who we've used virtual reality with. VR is not necessarily considered a mobile technology, but it's certainly mobile. So we'll talk a little bit about VR later in this discussion, about how we're using virtual reality as a therapeutic intervention and as an educational intervention for our patients. But I want to start with this picture. This is Aaron Jennings. He's a cardiologist. And at this moment, he's in a digital coordination center monitoring his population of patients. And he's looking on the screen, and he sees one of his patients who has cardiovascular disease. And this patient has a remote EKG sensor on his body. And Aaron is noticing ST elevations at this moment and is concerned that this patient that he's watching is having a heart attack. So he picks up the phone and he calls the patient's cell phone and he says, Mr. Johnson, how are you feeling? And Mr. Johnson says, I feel okay. He says, okay, well, here's the thing. I'm afraid you're having a heart attack. I need you to take an aspirin and come into the emergency department immediately. And this is, of course, the vision of the whole purpose of our being here is how can we use these technologies to engage our patients beyond the four walls of the hospital or the clinic or the emergency department or the eHub. This is called the eHub, except this is a television show that's been on CBS. This is actually a $7 million set on the back lot of Universal Studios. There's a TV show called Pure Genius that was on last season on CBS. We were fortunate to help work with the producers to develop some of the storylines and to sort of visualize what this fantastical future might be if and when we actually can create this type of infrastructure to engage our patients beyond research studies and sort of, ideation. So we are actually doing a version of this, and these technologies do exist. This is one of the technologies that we use quite routinely now. This is an FDA-approved technology. You may be aware of this. It's called Cardia by Livecore. And this particular sensor is very simple. It can stick on the back of a smartphone. You put your fingers on it, and it's lead. It's a lead. I think it's lead one of an EKG, and it works. It can go on on a watch, or we have backdoor entrance so that we can actually monitor our patients routinely. And we use a sort of what they call a deep learning model. And what that does is after about 30 measurements, the computer can estimate the patient's electrocardiographic sort of profile. And then if there are deviations from that profile that appear to be statistically meaningful, the computer will signal that and will let us know that there appears to be something different from this patient's background EKG. Whether that means that there are changes in ST or other segments of the EKG, or if it means that there's a new arrhythmia that's developed, the computer will identify that and signal us when that has occurred. And we are, in fact, using this, and I'll show you how in a research capacity in a second, but the whole idea is how do we actually do this and scale this in real life? So whether it's the Livecore or any number of other sensors that I'm sure many of you are now wearing or have friends that are wearing, this is actually the Welt belt, which is, as far as I know, the only wearable belt. All belts are wearable. It's kind of funny. So that's the idea, is if you're going to wear it anyway, we might as well put a computer in it. And I actually happen to have this belt. I'm not wearing it right now, which goes to show how effective it is, I guess. So, if we think about what we're trying to do here with mobile health, from the standpoint of a health system, and we heard a little bit about this in the excellent last presentation, we're all sitting in these healthcare facilities, these four walls that geographically and physically bound us to these locations. But of course, our patients are out in the free-range world. But increasingly, they're digitally connected. Now, typically, we'll see our patients in person. They'll come in and see us, or maybe we'll engage with them through a patient-provider portal. Not too often, and usually begrudgingly for many doctors. But we'll see them in person. But of course, our patients have access, as we've been hearing, to all of these different technologies. But the idea is all the data that's pouring off of these sensors, and we saw some great examples in the last talk, who is in charge of monitoring all of the data? Who is deputized with the responsibility, medical legally, clinically, to monitor these patients? It certainly is not going to be these people. No chance are the clinicians who are busy seeing patients one at a time are also going to be monitoring patients, these large groups of patients in the community. It's not going to happen. And I'll show you some evidence of that, at least from our own health system, in a little bit. So the idea is that we have somebody like Aaron Jennings, who I showed you in that first picture. That actually is his name, although he's an actor, he's not a cardiologist. But can we have a digital command center, and increasingly there are health systems doing this sort of work, where there are clinicians, and they don't have to be doctors, who are trained in a combination of digital health science and behavioral health, and obviously clinical medicine, and can monitor the biometrics coming off of these sensors, and are increasingly able to measure biometrics, psychometrics, and biomarkers. And I'll show you in a second, are able to measure biomarkers at home now with a little blood stick. I'll show you more about that in a second. So, these clinicians in the digital command center will then engage directly with the patient, whether it's through picking up a phone or maybe even seeing a patient in person. When they see that combination of behavioral changes or other signatures, signal in the noise that might suggest a psychiatric, break or some kind of significant clinical decrement, well, maybe it's the person in the digital command center who sees that and engages directly with the patient, rather than expecting these folks to drop everything they're doing and to start working with the patient directly when they don't really necessarily know how to do that. When the patient needs to be seen in person, that's when the digital command center works directly with us in the clinical trenches and says, hey, we are seeing some problems here. I've got your back. This is what's been going on. But now this person needs to be seen directly and in person. So rather than sort of waiting arbitrarily, like when I see somebody in clinic, I say, come back in 6 weeks, right? Well, what's going to be happening in 6 weeks? I have no idea. I'm just estimating based upon this patient's natural history of their disease that 6 weeks from now, it might be a good time to see the patient. Maybe they need to be seen in 6 days. Maybe they need to be seen in 6 years or 6 months. So the point is that we don't always know because we don't have a way of monitoring our patients. This is a picture of my clinic where I saw patients just yesterday, and it looks like any other clinic pretty much ever, except, even in the 1950s, our clinics looked like this, except we have this computer now in the middle that kind of physically and emotionally separates us from our patients. So, it's a system that was designed to support the administrative needs of billers and administrators, frankly, kind of transactional needs, not to support the deep human connection between patient and provider, but that's my soapbox for a second. But patients do not come to this room willingly, not usually. They spend 99.9% of their lives far away from the clinic. Coming here is kind of like going to the DMV. No one wants to go to the DMV. You go because you have to. You go because you're going to get a service out of it, but you know that you're going to be waiting in lines, that's going to be kind of beige and bland without a lot of windows, that you're not going to be treated particularly well. And then you leave. No one lives at the DMV. You get out of there as quickly as you went in. So that's the same thing as as this room. Our patients are gone. They are at home, as we've seen. They're at the park. They're at senior centers. They're at work. They are not here. So here we've got 15 minutes to take these deep biopsychosocial histories, figure out what we're going to do with our patients, and then make a decision, and off they go without ever seeing them again, except for these informal, occasional connecting points where we pick up a phone maybe or have a patient-provider portal interaction. So that, of course, is the whole idea behind mobile health, is that, between these points, all sorts of things can happen. For example, somebody can show up in the emergency department with a heart attack, which happens all the time. I have no doubt right now across the street in the emergency department, there's 2 or 3 people right now being ruled out for an MI, and certainly at Cedars, there's just as many. And in many of those cases, people actually didn't see it coming. They had just been seen in the doctor's office 2 months ago, and things looked okay. But what was happening here in the middle that maybe we could have identified, as we've been seeing with the mental health examples? Is there an opportunity for remote monitoring to fill in the blanks for some of these types of conditions? And in this case, when we think about remote monitoring, going back to the conceptual framework I showed earlier, we're thinking about biomarkers, psychomarkers, and biometrics. So here's an example of a study that we're doing, that we're just finishing right now, that was supported by the California Initiative to Advance Precision Medicine, CAPM it's called. And I love living in a state that loves science. Our state, through the governor's office, has supported CAPM as a trans-state initiative to support precision medicine initiatives. And our state views mobile health as very squarely within the precision medicine framework. We need to precisely understand patients' phenotyping, genotyping, and everything in between. So in this case, what we're doing is seeing if we can predict early evidence of major adverse cardiovascular events, or MACE, using remote monitoring in a cohort of patients. So what we've been doing with these patients is, at home, they stick their finger with this little lance, and they dip it into a well, and then they send it to us in the mail. And from there, we can test over 500 different biomarkers. We can do proteomics, lipidomics, all sorts of different omics on this little sample of blood. This is not Theranos, for those of you that are following that debacle. This is actually FDA-cleared technology. It's called the Mitra Device. And we're able to actually remotely monitor all sorts of interesting biometrics that we wouldn't normally be able to measure, like highly sensitive troponin, highly sensitive CRP. These are predictive in heart disease for cardiovascular outcomes. We also are using, in this case, Fitbit. We're currently using the Charge 2, but there's all sorts of other devices, and we're using the Livecore device, and we're also using apps to monitor patients in terms of patient-reported outcomes, the psychometrics. So we're using PROMIS, the NIH Patient-Reported Outcome Measurement Information System, among other disease-targeted instruments to monitor these patients. And we'll have more data soon, but one thing I'll add is, in order to get funded by CIAPM, we also have to evaluate the potential cost effectiveness of this strategy if we were to actually scale this in everyday clinical practice. So one of the hats that I wear is I teach cost effectiveness analysis here at UCLA. So we have a team that evaluates and projects what would be the resources to actually stand up a program like this, and how effective does it need to be in allowing us to intervene early and often in order for the upfront cost to be offset by downstream savings. And this is something that often is not discussed in the mobile health kind of community, is let's really get serious about the health economics of this, because if payers are going to pay for this, they need to see that there will be a return on investment for the resources that we're expending and putting these things up. And I'll come back to this in a little bit about whether this stuff is even working, and I mean from a high perspective. So to sort of set that up, I want to show you these headlines that came out a few years ago now. This was back in 2015, when my hospital, Cedars-Sinai, was, as far as we know, one of the first, if not the first, to offer Apple Health Kit and other APIs directly to our patients through our patient provider portal, so that our patients could connect their wearable data directly to our electronic health record through HIPAA-compliant channels. And it got a lot of attention, and we invited in this pilot study about 80,000 patients to connect their data to our EHR. And this looked really great, and this was really, a fun kind of, time to sort of have this opportunity to have data coming in that we can then analyze. Well, when these headlines came out, almost the next day, the doctors looked at each other and said, wait a second, did anyone check with us on this? Like, wait a second, who is going to be monitoring the data? It's not going to be me. And they said, wait a second, like, could you imagine, somebody told me, if Boeing sent out an email on a Monday to its 777 pilots and said, all right, guys, guess what? We've got some new data in the cockpit, we've got some new dials, and we've got some new visualizations, and we don't exactly know how to use it yet, but we're going to work together. We're going to see how it goes. You let us know what your experience in the cockpit is with these new data streams, right? It never would have happened that way. There would have been all sorts of beta testing and user testing and feedback, and, you know, that didn't happen here. So what we told our patients was, no, don't expect the doctors are going to be monitoring you, but when you come in, those data will be available to the doctor. So if you want to go over it with the doctor, you can. So that was the proposition, and we published this paper about our experience with it. This was in about a year or two ago, PLOS 1. And I'm blanking out some data on purpose for a second so that you can stay on the edge of your seat. So we invited about 80,000 people to connect their data with our electronic health record. And the question is, how many people do you think took us up on the offer to connect their data? What percentage of people said, yeah, that sounds like a good idea. I'm going to give my doctor and my health system some of my data. What do you guys think? 1,000 people? Who said that? Okay, so cynical. Oh, you already read it. Okay. The quick one back there. So what percentage? 1,000 people? Any other guesses? Have you already read? I think I blanked out the answer. But you're right. It wasn't very successful. Okay, so I'll jump ahead. It turned out 499. It was less than 1,000. Not cynical at all. That would have been ambitious. So this was, at the time, one of the largest, like, free-range studies of mobile health sort of use in the community. And yet, at the same time, it was kind of like a massive failure. 0.8% of people said, that sounds like a good idea. But then we said, well, who were these people that connected? You know, we had a lot of data on them. Well, it turned out it was generally healthy, younger employees of Cedars-Sinai Health System. That's who said, that sounds like a good idea. So you may remember this movie. You guys remember this movie? If you build it, they will come, Kevin Costner. Yeah, if you build it, they will not come. No, there's no reason people are going to say, that sounds like a great idea. It looks great on paper, or there's some, someone wrote a paper about it. But like people are worried about all sorts of things. Is my data secure? That's, obviously a huge issue that every day we hear about data breaches. So people are worried, like, I'm going to start giving you my pulse oxygenation data, or my blood pressure data, or my steps, or my sleep, or, what are you trying to figure out about me? But then there's just sort of like, well, what are you going to do with the data? Now, I actually want to let you know that for the example I just gave earlier, the cardiology example, we have about 90% compliance with the Fitbit in that study. And that's very high. It's one of the highest that we've seen that's been recorded. And, the question is, why are people so willing in that example to use the Fitbits, but in this example not? And, don't know for sure, but a lot of it has to do with understanding why they're doing it. These are all patients who have severe cardiovascular disease, understand what the study is about, and seem to have been engaged in a meaningful way by our research assistants, our research team. So, if you build it, they will not come, but you have to put a lot of TLC into it. But yet, despite that, we see these kinds of headlines that insurance companies, and we see, Oscar out here, and there are many others, are, working with Apple and working with other companies to start affixing wearables onto their patients' bodies in the hopes that that will spur positive health behaviors, that will engage people to be healthier, to walk more, to lower their blood pressure. And that's sort of the hypothesis behind this. But what is the evidence that using wearables, and I mean just in general, actually improves clinical outcomes? And I mean like clinically meaningful outcomes. Like, does it drop hemoglobin A1C in diabetics if we use wearables? Does it reduce blood pressure? Does it lead people to lose weight? So we just recently published earlier this year, this meta-analysis. This is a new journal, by the way, Eric Topol has put out at a Scripps. It's called Digital Medicine. I happen to be an editor, one of the associate editors on this journal, and invite you to take a look at it. So we published this paper in Digital Medicine and impact of remote patient monitoring on clinical outcomes and updated meta-analysis of randomized controlled trials. So our thinking was, let's just go to the randomized controlled trials. Let's find a study or studies where one group had some kind of a wearable, and we had a fairly broad definition of that. It pretty much touches the body and collects data. The data has to then be transmitted to a healthcare system or some component of a healthcare system, like a provider or somebody who looks at the data, and the data needs to be sent back to the patient in some way, compared to a control group that does not have that. And it was kind of a broad approach. And it turned out, in the history of the world, we found, I think it was 27 studies that did that, and the last important part was there had to be a clinically important outcome. So we weren't just looking at compliance, for example. We weren't looking at validating the sensor versus some other gold standard. The question was, do people get better? Like, at the end of the day, do they weigh less? Do they have lower blood pressure? Do they have lower hemoglobin A1Cs, or whatever the outcome was? And so, as you can imagine, these 27 studies cover a wide variety of different conditions. So I can't go through all 27 of them, but here are three conditions, or three outcomes, I should say, where we had enough to actually do quantitative meta-analysis, one looking at studies that evaluated BMI as an outcome, one looking at weight, which of course is associated with BMI, and one looking at blood pressure. And in all three cases, although there was sort of a trend towards an improvement, they were not statistically significant. One was very close, but not statistically significant when we looked at sort of overall, is there a statistically significant impact of using these approaches on outcomes? Now, there were individual studies, of course, that were significantly positive, and many that were significantly negative. And we can go through all this, all of these literature at some point. But I just want to summarize some kind of big lessons that we learned from looking at these trials. Maybe some of these are kind of qualitative lessons too. What doesn't work? Well, just handing somebody a tracker, which sort of is obvious, is not going to do it. People won't wear it. And that's kind of what happened with our example, is we just said, hey, put on a tracker without providing a whole lot of explanation or why you should do it. People aren't just going to put on a tracker. These always work better when they're in the context of some broader intervention with a behavioral health component. That always helps if there's actually a human involved in communicating with the patient. Generic motivational messages don't really work well, and that kind of makes sense, right? Like when you get this thing that says, hey, you have 4,600 steps left today, I don't think, wow, I better get moving. I think great, that's almost demotivating me, and there's some evidence of that's the case. Whereas another message might look up your sort of readiness for change. It might look up the weather. It might look up your steps, and then say, hey, today's a really nice day. When you're ready to go out for a walk, this would be the kind of day when you might want to do that. That's a very different message that it resonates more meaningfully with patients than you have 7,000 steps left. Paying people to do this, so that doesn't work. Constant and intrusive monitoring, that doesn't work. But things that do work, and I've sort of identified these already, is combining these with other support programs, social incentives, avoiding alert fatigue, and this notion of hyper-personalization. And an example of that is what I just gave you, where you look up the patient's unique characteristics. So this term hyper-personalization was really put forward by Dr. Kvedar, Joe Kvedar, who's at Harvard in the Connected Health Institute there. And he wrote this book called The Internet of Healthy Things, which if you haven't read, I recommend reading. It's a very nice book that goes through his experiences over many decades now doing this type of work. And I've really learned a lot from speaking with him and reading his stuff. And in it, he has a whole chapter on hyper-personalization. We really listen to the user and provide tailored guidance and consider the patient's readiness for change, which is a very old, established concept in behavioral health. The stages of change model, the whole idea that patients go through different stages. This sort of so-called trans-theoretical model, where some are not even ready to thinking about doing anything about their health. And some are now maybe ready to think about doing something about their health. Others are now at the point where they're preparing to do something. Some are now acting, and so on. And the way we engage with patients along the spectrum, which is well known in any behavioral scientist, is different. But in mobile health, everyone sometimes often gets the exact same message. You have 7,000 steps left. Okay, great. Well, I'm taking off my sensor now for somebody who's pre-contemplative. But somebody who's in the action stage or the maintenance stage, that might be an appropriate message. So this brings up this whole idea of integrating behavioral health sciences with mobile health, and we have some experts in the room around that. And I refer frequently to this excellent article that was published a couple years ago by Muma and colleagues. It's called the IDEAS Framework. This is the Integrate, Design, Assess, and Share Framework, which is an outstanding document that I use often. It's a checklist of best practices for developing digital health interventions. And it's sort of a composite of other established frameworks, but it has been tailored specifically to digital health interventions. And I have all my students read this and apply this in their projects, and I'd recommend you take a look at this if you're interested in this work. I just want to give you a couple other examples as I finish up, where we've been trying to think about behavioral health and thinking about pragmatic uses of wearables in the clinical trenches. In this example, we're dealing with a very important problem, very common problem, which is after somebody has undergone surgery, we all know one of the most important things to do is to get up and walk. You have to get up and walk around. It's a very low-tech, highly effective way to improve outcomes, reduce infections, reduce clots, reduce all sorts of things, and even reduce length of stay. The current standard of care for doing this is some doctor writes, some of you who are doctors know this, right? OOB to chair, right? Out of bed to chair. That's the state of the art, is you say, you go walk. And then we have no idea how far somebody has actually walked or not walked, or how far they should be walking. So let me see if this works. Yeah. Patients need to walk after they've had a surgery. There's decades of research, so we know that. So this is a really simple use case where we can use Fitbit to do something that's actionable. We can act upon data. And by giving that data back to the patient through the television set, it engages them so that they're more likely to do what they're supposed to do.
What we've done is actually created art tours that relate to specific step counts. So there are tours that relate to, say, for example, 250 steps. So it really engages patients to get out and walk for a reason. We're in a position as physicians to sort of see the unmet needs and the opportunities to intersect technology on the front lines of care in the clinical trenches. And I think that's what we're trying to do with this Fitbit example. It's really exciting to see patients take something to use and at home and actually bring that into the hospital environment and have it be part of clinical care and have it be relevant. And I think that's the excitement of digital health and what we do.
So as you saw in this example, we're using objects that are already in the patient's environment. In this case, the television set, which sits there all day, and patients are looking at. Rather than bringing in iPads or all sorts of other stuff, we've got a television set sitting right there. So what we do is we kind of gamify this, and the patients can see how far they should be walking, and they have to chase that flag around the track throughout the day. And then they see how they compare to other patients in the hospital who have had the same surgery and are the same post-op day. So they can sort of be motivated to engage and to walk. And this is an example of somebody who's way ahead and got a star for the number of steps that she took. And you saw the part about the art tours. We're fortunate at Cedars, like many hospitals, have sort of beautiful artwork all around the wards. So what we've done is we've created an app where the artists themselves have narrated short descriptions of their artwork. And we prescribe an art tour to the patient. So they then, when we know how many steps that art tour takes on average, so that the patients now can walk around and have a reason for walking, learn about the art in the hospital around them, engage with their physical environment, and hopefully help them physically, emotionally, biopsychosocially at the same time. Now, I'm just about out of time, but I do want to finish with one last example of virtual reality. And how many of you have used virtual reality? Okay, about half. So every time I ask that question, there's usually one or two more hands than there was before. So this is an example of virtual reality. This is actually the first time that I used virtual reality. I was put on the side of a building, and this is me. And it's hard to tell on the two-dimensional screen what it actually feels like in three-dimensional immersive virtual reality. It sort of hijacks your brain. And I'm going up the side of this building, and you can hear the sound, and I'm looking around, and it's all animated, but it feels extremely realistic. And as I'm going up, I'm noticing these little details like the creaking of the cables and the light shining off of these buildings. And there's down way below now, like 50 stories down, there's this rotary. And I'm feeling fairly safe because there's this rail there that's sort of holding me back. And I look over the edge, and I'm thinking, okay, I'm a little bit afraid of heights, but I can probably manage this. And then all of a sudden, this happens. And I just freak out, and I go back on the wall. And they said, no, just relax. You know that your feet are on carpet, right? I said, my feet know that, but my brain doesn't know that. My brain thinks I'm about to die. I'm about to die. They said, well, listen, just jump off this thing. I said, no chance. I'm not jumping off of this thing. I said, no, just jump off of it. I thought, no way. But the only way I was able to even think about it is there was a little crack in the face mask, and I was able to see through it, and I could see the carpet, which was this little tiny stable point in an otherwise dynamic virtual environment, which gave me just enough bravery to take a little baby step off the side of this ledge and jump off of this building and fall all the way down 50 stories to my virtual death. And there I go. So I thought, man, if this could be used for evil, maybe we can use it for good. So I'll finish with this. This is what it's like to be in a hospital all day, and people sit around looking at ceilings and looking at televisions, and every so often, something like this happens, and we disappear and come back again all day long. But here's a patient, one of our patients, who's been escaping from the room, escaping from the four walls of the hospital, and going on fantastical sort of journeys. And I'll show you, this is my last bit, I'll show you a very brief video of two patients going through this. And I'll end. And you can sort of get a feeling of what it's like for our patients that have been using this virtual reality.
So we'll see if it helps with you'll tell us. Yeah. And we'll go from there. Okay, any questions about that? Good load up. Yeah, okay. Is that working? Yes. What's happening now?
The helicopter, waterfalls.
Have you ever been to Iceland?
No.
But the music and everything is real peaceful. Oh, it's people.
What do you think?
Relaxing. Like that you're there, like you're really big, waterfall and everything. Look around the whole scenery, like you're immersed in.
How does it make you feel?
Relaxed. Very relaxed. I wasn't thinking about pain.
You weren't?
No, I wasn't.
Really?
I was just thinking about being there.
Well, let Dr. Herman know.
Okay, thank you. Thank you.
Good, okay.
Yes, but I really did like it. I enjoyed it. Thank you so much
You're
for
welcome.
taking me.
So along with that, that's just an example where we're using technology to try to engage patients, and some other time I can tell you more about the results of that study. We've been able to reduce pain without opioids and engage patients, improve quality of life, and get them out of the hospital sooner. So I thank you for your attention today. Thanks for inviting me to be with you guys, and enjoy the rest of the day.